Welcome, everyone. We're just going to wait a couple more minutes just to make sure everyone has joined our webinar. But tonight we are going to be talking about lumbar pars stress injuries. We've got an amazing panel of hosts that are going to be talking to you from a few different clinical angles about how to manage these injuries. So, like I said, let's give it a couple more minutes before everyone can jump on, and then we'll dive right in. So use this time to get yourself a cup of tea, biscuit, stretch your legs, because we've got some really exciting stuff, so you won't want to have a break. I'm just going to load up the presentation that I've got now. If everyone's gives me a thumbs up if that's loaded, that'd be great. You looking good? Cool. All right, I reckon we might make a little start now. So tonight we are talking about lumbar pars stress injuries, specifically in young athletes. So this is the rising tide of bone stress injuries in young athletes, presented by Mayfair Health. My name is Sam Charles. I'm one of the lead physiotherapists at Mayfair Health, clinic based in London. And I run the bone health program that we have here. And I'm going to be your host tonight. We're going to be talking all about bone stress injuries in the lower back, in lumbar pars stress fractures. So why are we here? Well, we are here to try and provide a platform for education for clinicians, for parents, for individuals who have this injury, to try and get to the nitty-gritty of why these injuries occur, how we can manage them. And we've got an incredible panel of presenters talking to you tonight from different clinical perspectives about these injuries. So we're seeing rates rise. We are seeing more and more bone stress injuries in younger, less specialized athletes than ever before. This used to be an elite issue, an elite problem for those who were at the top level of their sports. Now it's happening in kids that are younger, kids that are not specifically trained, or kids that aren't at a semi-professional or even professional level. So this is happening in schools, it's happening in academies, especially football and cricket academies. And it's also happening to recreational runners, the weekend warriors playing Sunday football, and kids who just love their sport and parents who want to give them what they want. The profile's changed. It's not just the elite athlete, but it is those who are undertrained, overloaded, early specialized, those who don't understand about their nutrition, about their energy availability, those who are in a position where they're not informed or educated to know what to do or know how to recognize the signs and symptoms. That's what we're here tonight to address. This pattern is consistent across every sport that we see. So tonight's mission is to understand the pathway of athletes with past stress injuries and how to effectively manage them. On the right, we've got a graph that I just pulled up from a study done in 2019 in a BMJ article that looked at the incidence and the prevalence of past stress injuries in English county cricket players. So we are seeing that at the end of the season, these cricketers are having past stress injuries, and it's often occurring from the ages of 18 to 24. But we're also seeing this happen way, way younger. So it's important to get educated early, even when there isn't an issue, because if we can prevent these injuries from occurring and manage our load effectively, then we set ourselves up to be really successful, not only in our sport, but in the body health that we have in the long term. So where do these bone stress injuries occur? Typically, they occur in the tibia, more colloquially known as shin splints. So that's at 49% of these young athletes. In the metatarsals as well, common in football and dance. The femoral neck, which has a very high risk of having avascular necrosis where the bone doesn't heal properly. But tonight we're going to specifically lock in and focus on lumbar pars injuries. So the pars interarticularis stress fracture. These happen in footballers, in gymnasts, in fast bowlers, especially in cricket, and these are rising in these youth academies. So in terms of past stress fractures, what are some of the statistics that we're seeing these days? 47% of adolescent athletes with chronic lower back pain has spondylolisthesis. 60% of lower back pain that lasts for greater than 3 months in youth sport is often indicative of a pars stress injury. 6 to 9 months is the average delay for symptoms to correct diagnosis. So these kids are getting missed. They're continuing to load. They're getting written off as just having some back pain or a back strain. And then they're continuing to be more and more damage that then sets them up for greater failure later down the track. 71% of these kids, even if they are referred for an X-ray or imaging, have a plain X-ray at first presentation. So that's why MRI grading is the gold standard, looking from grade 1, which is bone marrow edema, which often heals with rest, to up until grade 4, which is a complete fracture and non-union, which may need surgery, but it's something we massively want to avoid. So to help bring this topic to light and really go into the nitty-gritty, we've got an incredible panel of experts. We've got Dr. Alexander Montgomery, who is a consultant orthopedic spinal surgeon from the Cleveland Clinic. He is incredible. I've seen him speak many times. He treats elite athletes coming from the Premier League, England and Wales rugby, the British Olympic team, professional boxing, cricket, and national ballet. He is the regional lead for spinal surgery, and he is amazing at helping to empower people to not only improve and recover, but to know what to do in the future to ensure that they're not going to be injured again. We have Vishal Kanji, who is a specialist physiotherapist here at Mayfair Health. He has an incredible career spanning county cricket at Essex County, and he was the head of performance and physiotherapy there. He has a fantastic framework for how to manage these past stress injuries in young athletes and fast bowlers, and he's going to talk to us about the rehabilitation and the treatment for these injuries. We've then also got Nicola Marsh, who's a registered dietitian, sports nutritionist, and a Team GB athlete herself. She is lucky enough, or we're lucky enough to have her here at Mayfair Health, and she is an expert in athlete nutrition, recovery, relative energy deficiency syndrome, looking at how to fuel athletes to recover, to perform, and to also stay injury free. So we're very, very lucky to have all three of those speakers. So we're going to start with Dr. Alexander Montgomery, talking about the diagnosis management of past stress injuries in young athletes. Then we're going to go into Vish, who's going to talk about how to rehabilitate these young athletes with past stress injuries. And then on to Nicola, who's talking about how nutrition can accelerate recovery from a bone stress injury. Then we're going to finish. We're going to answer some of your questions. So if you can see in the box, we've got the Q&A. If you start putting questions in throughout the evening, we're going to start to collate them. And at the very end, we'll have a Q&A where I'll lead a panel discussion with our experts talking about the answers to your questions. And we're also going to have some poll questions come up throughout each presentation. So if you want to answer them, just so we can get a feel for what the audience is thinking, and then hopefully dispel some myths or help entrench some further truths. So without further ado, I'm going to stop sharing. I'm going to pass over to Dr. Montgomery.
Right, thank you. Let me just see if we can get this on. Thanks very much, and welcome everyone tonight, and thanks for coming. Yeah, my name's Alexander Montgomery. Everyone calls me Monty. I'm a spinal surgeon, orthopedically trained, based at the Cleveland Clinic in London solely. We have our main hospital in Grosvenor Place, with an extension of a cancer unit opening, a cancer and sports unit opening next year. We also have outpatient centres in Moorgate and in the Oxford Street area. So yes, apart from doing the degenerative and normal kind of run-of-the-mill spinal conditions that everyone sees a lot, I do deformity work as well. But my main USP is really in the sports world, and it's not just elite. I see elite, semi-elite, amateur, and your kind of weekly athlete, your city person that likes to do the triathlon, that kind of thing. So all spectrums of this, and like I said, working football, rugby, cricket, boxing, tennis, pretty much most sports, to be honest, and some other things like ballet. My background is I was tasked with setting up a spinal unit for North East London at the Royal London at Barts, where it didn't exist about 15 years ago. Did that and led it for about a decade. And then moved on to be regional lead of spine surgery for Essex and North London region for about 4 years, sort of standardizing pathways and care across the region. And I've, as I've just told the rest of the panel, I've just actually recently resigned from that. So I'll be focusing solely on my work at Cleveland Clinic and the sports stuff. So I see a lot of young athletes, and at certain times of the year, like when the football season starts, and not when it starts, but when the signing starts in August, it gets very busy with people coming to me with scans of asymptomatic teenagers or people in their who are 19, 20, 21 who've got pars injuries. So actually, there are two main things that the younger people get. There's pars injuries, and there's also disc-related issues, which is also on the increase. Disc bulges, disc prolapses. But today we're going to talk about the pars injuries. Um, so the human, when you're dealing with any spinal issue, whether it's back pain or leg symptoms or deformity-related pain, the human body is pretty complicated, right? You know, there's so many factors: joints, tendons, muscles. You know, there's nerves, there's a spinal cord, there's people. Everyone's strength and stability is different. What they do every day is different. Their diet's different. Genetics different. It's really complicated. There's no research study that focuses on that one person. But actually, you can make it quite simple for patients or anyone to understand. And that the basic fact is, if you have a load going through your spine, and that load on a daily basis over a period of time exceeds its capability to deal with it, then things are going to start getting inflamed. And in the young athlete, they start getting edema or inflammation in the bone. Then they start getting fractures, microfractures. Then they start getting incomplete fractures. Then they get a full fracture, as those gradings you saw just now showed. But that principle goes through for back pain and any other spinal condition. So the point of management is that we need to increase their capability of being able to deal with what goes through the load that goes through their spine every day, and whether that's with physio and strength and conditioning or Pilates or through diet or nutrition or sleep, importantly, and modifying their activities to readdress that balance. But the important question here with regards to past stress injuries and young adults and kids is, does the bone respond to loading in the same way that muscle does? And my answer to that would be no, because kids are able to, when I say kids, I'm talking about anyone from 10 to 23, by the way, they are able to strengthen their muscles. They don't really get that many injuries with it. But the bone doesn't seem to respond in the same way in terms of its strength and how much it increases. So because it can't cope, you get these kind of stress responses. So what about pars injuries? So it's a defect of the pars where their arrow is. You can see there's an arrow there pointing towards the pars, and there's a break in that particular one on that right-hand side. Most commonly seen at L5 and then at L4. It can be on both sides in 80% of cases. And it can occur at more than one level. So at the extreme, you can get both sides bilateral at 2 or 3 levels. And what does it do? Well, it can be completely asymptomatic. It can cause pain, but it can diminish the stability of the spine and result in what we call an isthmic spondylolisthesis or a slip. And you can see here at L5S1 on the side here, there's a big slip of the bone there, which can develop sometimes earlier on, but more often later on in life. So the younger presentation of it is either they don't present with it at all, or it's just pain. But as you get older and into your 30s, 40s, 50s, it presents more the pain associated with the spondylolisthesis. So its incidence, we mentioned that before, and I think you said earlier, Sam, it was 40%. So, in the general population, about 3 to 12% in different studies. And in the young athletes, it's been recorded in different papers as 23 to 63%. So I would say an accurate figure is about 40% of athletes and people that come out of football academies and cricket academies and young cricketers. So it's highly prevalent. In terms of when you see it, I mean, you can see it at any age because they can be asymptomatic. But when do they come on? It can often develop when they're between 7 and 10 years old. It's quite rare before then. And getting it for the first time after 20, again, I guess is less common. But what's most common in the literature, from what I've found, is that it is asymptomatic. It's quiescent when you're younger, and then it just presents at a later date. Or you remember one episode of back pain that happened, and you didn't think much of it. You just back went into spasm for a while, and then it calmed down. That story I get quite a lot. So quite often it'll be there from younger years. And so there is some evidence suggesting there's a genetic predisposition. I think predisposition. I think you can say for most things in the spine there is a genetic predisposition, especially disc-related issues. Um, the single traumatic event is very rare for it to be a fracture. Most of the time we're talking about repetitive mechanical stress and micro trauma. Um, and that part happens to be a weak area of a junctional area where a load of stress goes through and it hasn't got the ability to deal with it. And it certainly doesn't strengthen that particular area. It certainly doesn't strengthen or harden in the way that muscle does when you're training. Um, what about symptoms? Most patients do not experience pain. So about 80% of people do not have symptoms. Their studies have shown that actually are more likely to get symptoms if it's bilateral. I think that's common sense because they can flare up, they can go quiet, they can harden up or what we call sclerose, or they can heal. And they can flare up at certain times, whether that's just edema or a stress response, or whether it's an incomplete or complete fracture. And if you've got two, like one on each side or bilateral at two levels, then it's more likely to happen. So about 20% of them do become symptomatic with them in young adults, and that generally coincides with the growth spurt. And you can assume that's because they build up more load and they start building more muscle mass and they start doing more with themselves as they grow older, and so it puts more stress on that particular weak spot, which is the pars. And I think it accounts for a significant amount of back pain in young adults. So what about radiology? Well, MRI is always the gold standard for anything spine related. In general, I'd say apart from high energy trauma. So if you are hit by a bus, unfortunately, well, if someone is hit by a bus and they go to an A&E, you're going to get CT because you need to look for primarily for a fracture first. But apart from high energy trauma, the MRI is always the gold standard. Why is that? There's a lot of detail, as you know. You can see bone, you can see disc, you can see nerves, you can see spinal cord, you can see all the soft tissue and muscle. You can see muscle wasting, you can see muscle bulk. There's all sorts you can see there. And there is zero radiation. So obviously, for both adults and kids, that's better. For kids, it's excellent because they don't get exposed to any radiation. There is this sequence called the T1 vibe, which we use a lot, which is a particular sequence in the MRI that mimics a CT. It's not quite as good as a CT, but it mimics it, and I'll show you an image a bit later on about of a T1 vibe. The reason to have this is it prevents, most of the time prevents the young patients from exposing themselves to radiation with a CT. And if you can't see it, then we do a limited CT. You don't have to CT the whole spine or whatever. You could just CT that small area. And then we have this thing called the SPECT scan, which is basically a radionuclide scan. It's with contrast, radionuclide contrast, coupled with a CT. And it can be an extremely useful test because it can not only show the detail that a CT does, which is excellent detail for a pars defect, but it can also show whether it's active or not. It won't show if it's mild or mild to moderate. It'll only show moderate to significant activity, and that the relevance of the activity, which shows up as a hotspot, is that it has a higher correlation to being the source of the pain. The other thing we do is flexion extension X-rays sometimes, and that's really if there's ongoing pain and we haven't got resolved it, or if you're planning surgery, we want to see if this part of the reason they have pain is because they're unstable, as in there's movement in the vertebra. So here's a T1 vibe. So on the left-hand side here, it's a side view of the vertebra. And I've purposely chosen this one because there are some that are better than others. Some are clearer than this, some are not as clear as this. This is an average one. So you can see it's not amazingly clear, but you can see the pars here leading from the vertebra to the back of the vertebra there at the bottom. And that's not a CT. It looks like a CT, but it's actually a T1 vibe MRI. So there was no radiation involved in this image. And just to show you what a CT looks like, that's a CT on the right-hand side. So you can see there is a difference, but in terms of the clarity of the image, but the big difference here between the left-hand image and the right-hand image is the right-hand image had about the equivalent of 50 X-rays worth of radiation, and the left-hand image has had zero radiation. So it becomes a very useful adjunct to our radiology if we have access to it, which we should really. So the SPECT CT I mentioned, so this is what I mean about hotspots. You can see the top middle picture here shows a beautiful hotspot there, and patients like looking at that because that visualization of it often correlates to the source of their pain, and it's very reassuring when you can see a source of that pain. And as a surgeon, it helps tell me that the PARS are the cause of the pain they're getting. And if it's not, is it the facet joint? It might be the facet joint, might not be the PARS, and that's managed quite differently. Or is it something else? Is it the disc at the level above, or is it that level or the others, the level above or the level below? We normally use it for when we haven't managed to get on top of things, where pain is continuing and we're unsure as to whether we got the right diagnosis or the right level, especially if there's multiple levels involved. And this is the kind of flexion extension view here, the side view showing the slip there and the spondylolisthesis on the vertebra where it's just slipped one on the other. And you can see in the image on the right of the X-ray, it actually returns. So that is unstable because it's moving in extension, it moves backwards, and on the image on the left in flexion, it moves forward. So that can be a cause for ongoing pain that doesn't resolve with normal kind of rehab and injections. So what about the certain scenarios? Well, they can be, like I said, you can get chronic ones that have been ongoing for decades, which are symptomatic. You can get ones that look acute, which are asymptomatic. You can get bilateral chronic. They can be mixed. You can get them at two levels. You sometimes, because we know this because of football academies or the Premiership football clubs, they scan asymptomatic kids, and we know that kids that have had no pain for years or don't have any recollection of any pain ever sometimes have what looks like acute symptomatic PARS. So you very much have to go on the history, what they're telling you, and also with a pinch of salt, because you can imagine if someone's coming from the Brentford Academy and Chelsea want to sign them, they're not going to say I've been in pain for 2 years. So you have to use your own judgment as well. Muscle spasm is a big one. So if there's a lack of muscle spasm and the patient tells me, the player tells me that they have no pain, then that's more likely to be realistic. Obviously, tenderness at the spot. And I find putting them prone, lying on their front on the bed, and even going into extension more and palpating is quite a good test. But the muscle spasm actually gives a lot away. You can't hide that. And if it's there and it's not there elsewhere, like on the other side or above, then it gives you a good indication as well. And then at some point, with all the radiology and the history is really important. When did it start? When did you first have it? When did it go away? When did it restart? You have to decide as a clinician when day zero is, because then you can plan your rehab accordingly. Because if you're not on day zero, you're on day 40, that's a very different point to your rehab and your progress and your prognosis going forward. So you have to decide when this event happened. So treatment, well, it's all the usual stuff first: rest, anti-inflammatories, activity restriction, and rest doesn't mean not moving. It means you can still walk around and everything. What about bracing? So the bracing for me is all psychological, and it's for people that you think are not going to be compliant. If someone has an L5 fracture, like a trauma, we do not give them a brace because a brace ends at L5. Like if they get hit by a car or they fall off a horse or something, the brace ends at L5. So there's no point in putting a brace on for someone that has an issue at L5 because it's not doing anything, it's not supporting, it's not actually offering stability. So if it's not offering stability, why do some people give a brace? Because basically, if you think this kid is 17-year-old or whatever, 14-year-old, is not going to be compliant, and putting a brace on him is going to actually tell him he's got an injury, and everyone else around him knows he's got an injury, and he's more likely not to do something stupid, then that's the only reason to give it. Physiotherapy rehab is the gold standard for the management of pars injuries. And Michelle's going to go through that, so I'm not going to touch on that at all. Um, and then there's things that rheumatologists can help you with. So bone stimulators, the thing called osteospine. And then my colleague John Hatton, who deals a lot of stress injuries, he uses that, and it showed to have a significant impact on healing in pars injuries. I'll show you a picture of that in a second. Um, the bisphosphonates in teriparatide, that's often a discussion for resistant cases. There are pros and cons, there are risks and benefits as in side effects. So that needs to be discussed with the rheumatologist that you're dealing with. And my role is injections or surgery, and surgery is only in a small minority of those. So this is the osteospine. It's a kind of a stimulator, and there's quite a number of studies that have shown it increases fusion and healing rates in these pars stress fractures. For those of you wanting a good oversight of the entire picture of pars stress injuries, this is a good study, a good paper, sorry. It's a really good review on the non-operative side of it and things to pick up on and rehab side of things. So what about interventions? What about so injections is obviously something we consider, but you have to decide what the goal is here. What are you doing the injection for? We are not doing an injection in acute fracture. We're just trying to heal. That's not. We're not trying to take the pain away so that the player or the patient can do more. That's not the scenario we do it in, because that fracture needs to heal. That treatment of that is activity restriction, anti-inflammatories, rehab, and possibly the abrasive. That's the way you're inclined. The injection is really for those areas where there's a high signal or there's a chronic pars stress injury, because a lot of them don't necessarily heal in terms of bony fusion. They just scar up with soft tissue, and you still see a pars fracture there, but you can tell from its appearance it's old, and a lot of them are asymptomatic. But if they become symptomatic and it's a chronic pars stress injury, or there's a stress response, then that might be an indication to do it. Diagnostically, if you want to see that's the cause of the pain, or whether it's the facet joint that's the cause of the pain, or whether it's disc-related pain, you can inject around the disc. I recently had a patient player who had a disc prolapse pressing on one of the nerve roots and had a pars stress injury, and they were trying to work out where this buttock pain was coming from, and it was L5S1. So I did it for that reason. Of course, the main reason to do an injection is to aid rehab and give a better period of a lesser pain or no pain in order to carry that whole thing out. We don't do surgery much at all these days. It's very less commonly used now that our understanding of the rheumatological side, the rehab side, the medical side of it has improved. But when we do need to do it, we can do it under 3D navigation in the theatre, and it usually involves something called a pars screw. And that thing down there at the bottom is a 3D navigator where you get a 3D image of the pars. And that's really transformed the accuracy for this particular thing, because as you know, as you can see from the images, the pars area is very small, so your target is very small. And if you want to do it minimally invasive through tiny incisions, it's got to have some form of navigation. So the important thing to pick up about outcomes here is you look at that 89% and 81%. So 89% return to pre-injury level of sport for conservative treatment and 81% for surgical approaches. Now, it's a slightly unfair comparison because the 89% were successful in conservative treatment. The 81% were the ones that weren't successful, but were successful with surgery. So it's not a like-for-like comparison. But the overall point here is that we should be able to manage most or all of these with conservative means, whether it's rehab plus or minus an injection. And one should treat it as an ACL. It's not like, oh, it's pars stress injury, give it 6 weeks, give it 3 months. It's not. It's going to take 4 to 5 months to 9 months, and it could take a year. So kind of treat it almost like an ACL. So I often say, look, it's going to be 4.5 months at the minimum. And yeah, sure, there are some that beat the times, but they've got to be realistic that actually this is it's almost a season-ending injury if it's an acute fracture or is an acute exacerbation of fracture. So it's not a quick return to sport. It's quite important they know that. Sometimes you get a spondylolisthesis, and later in life you need a fixation for that. If all conservative treatments fail, this MRI scan on the left there shows the slip on the bone again. And these are generally, if all conservative treatment fails and they haven't, they're still in a lot of pain, then is treated with a fusion to stabilize it. And outcomes of that are actually very good when done in the right way and in the right person. But a lot of people actually don't need surgery for this either when they're adults, because you can actually, a lot of people manage through rehab and activity modification. And, the scars for that, if you do end up with surgery, you can do them minimally invasive. So, again, you can actually get people back to considerable sport. This lady here is a triathlete. She qualified. She was an Olympic triathlete and actually qualified for the Olympics after that surgery, which is quite rare. But you can't do collision sports, and not rugby, not football, that kind of stuff. Well, football is not collision, but it's kind of contact. Um, so what about pars injuries? So it's the take home here is it's extremely common in young athletes. It's also very common in the general population. So whenever you see a 10, 12, 14, 16-year-old who likes the sports and has back pain, I think it has to be a pars injury until proven otherwise. And I think it's increasing. It's increasing um, uh, because these kids are basically doing a lot more sport. When they go to these academies, they're training really hard. They're doing a lot more weights. They're doing a lot more training in there. They're doing a lot more gym work. They're kind of going home. They're not focusing on their energy deficiency requirements. They're not, in my opinion, at that age, they're not like the professional athletes. They're not eating the right food. They're not getting the right amount of sleep. Um, and they have social media as well. So they're kind of getting up, doing their training, hitting it really hard in the gym, hitting it really hard with the weights, hitting it really hard with their skills, and then not eating the right food, not getting the right sleep, sitting on their phones until late on social media, looking at other people doing all these training regimes and lifting heavy weights, and that cycle just continues. And for me, that's the reason why why this is increasing. The amount of load they're putting through is certainly increasing, and they're not keeping up with it with regards to their diet, with regards to their sleep and their recovery. And that really for me is the crucial factor in all of this. It's a kind of positive energy going through their spine and into that weak area of the pars without the right recovery and without the right nutrition to go with it. And the rehab is often when it's already happened. So you're kind of backtracking a bit. So taking into account all those lifestyle factors for me is going to be crucial to reducing the incidence of this and trying to both in the general population but also in the academies, which is much harder because they're under a lot more pressure. From a surgical point of view, the conservative treatment is as I said, is by far the best option, though surgery can be very effective. But it's something we need to think about because this generation of kids, if it's increasing 20 years down the line, we are all going to be dealing with a rising population of back pain in their 40s because of these injuries when they're younger. And it's very common. I see about probably half a dozen people a week in their 40s with this, and my guess is most of them got it when they were teenagers, and that's only going to increase. So, yeah, really important thing to get on top of. And I know a number of people have got grants for research studies for these kind of things. So, an important topic to understand the nutrition side of it, the sleep side of it, the rehab side of it, and how to prevent it, especially. Those are my contact details for anybody that want to ask any questions or relating to this or anything else spine related. Thank you very much.
Thank you so much, Monty. That was really awesome. Just breaking down the complexities around radiology, diagnosis, and then management. I think you just really summarized everything quite nicely. So thank you so much for that. Really appreciate it.
That's
All
right.
right. We're passing on to Vish now, who's going to go through the physiotherapy management and how to rehab these complex injuries. So I'll pass it over to you now, Vish.
Thanks very much, Sam. Monty, that was very good, mate. Thank you so much. I'm just going to share my screen now. Again, a very complex subject. Probably 20 minutes doesn't cut it, but I'll try my best. Hopefully everyone can see that. Yeah, a little bit about me. I've spent the last 11 to 12 years working in professional cricket. So this injury became a passion of mine simply because I saw so much of it. By no means, again, I can call myself an absolute expert at this. I'm still learning. The research is still developing. People are getting it when you don't expect them to get it. So yeah, again, we're all still learning. But yes, I've had a high caseload of these injuries, and I've been able to pick up quite a few traits, a few protocols I've put along in place, and yeah, seen some success with this injury. So work closely with Monty with these injuries as well, and it's always an MDT approach. So always nice to have a good team when dealing with injuries like this. Just a bit of an overview. I'm going to be talking to you about identifying it, and Monty's already done a good job of that. Some of the things that I will look at when someone's presented in front of me, talking about some of the risks, some of the subjective traits, some of the languages that I use to reassure patients, parents, clinicians, as well as coaches and parents. Some of the assessments and screening things that I've developed, some of the rehab phases, again, quite a complex topic, but try and cover it as much as I can. How do you reintegrate them back into sport, and some take-home tips? So when I'm in clinic or when I'm with a player, these are the things that I'm looking out for. A lot of them will say they have morning pain. And this is showing that there's some activity going on, maybe a little bit of inflammation. So we're just keeping an eye on that. A lot of people tell me it hurts when I bowl and I had to stop. And parents will also massively worry about this. Things like jumping, impact stuff hurts quite a bit. A big one that I see is someone will turn up and say, I play golf on a Monday, I play polo on a Tuesday, I play rugby on a Wednesday, I play cricket, and I do multiple sports. So that again just raises questions around how much are they doing, how much are they recovering in between, are they doing too much? So again, something to look at. Are they going through a growth spurt? And if they are, that's something to consider. Time in the season's a big thing. I think people who are saying, if you look at the cricket season that starts in March, they're coming to you in August. You're probably thinking they may have done too much and their workloads are too high. So again, something to think about. They often say it hurts more when I play sport. Severe pain in the car on the way home. An interesting one that I've noticed is a lot of kids say, "Oh, when I put my bag on one side, they get pain." So maybe some unilateral loading. They often say landing hurts, and it's another one that a lot of people don't look at and think of is educations, exams. Are they sitting for long periods of time? So a lot of pressure on that kid, um, as well as parents. The one thing I always look at in clinic, if they are turning up with parents, is that parent putting pressure on the kid, and if they are, that's again something to address because it doesn't matter how much rehab and amazing management you do, if the kid is getting pushed too hard, something to think about. Some of the language that I use, I try and keep it very simple. I'll present them with a four-stage approach. I say your back can have no stress, or you can have a fracture. You can have stress with no pain, and you can have stress with pain. If you're coming to see me and you're in pain, you're already at the stress mark. I would then refer on to a consultant for scans and images to see how far along they are, either in 3 or 4, or maybe even a slip. But again, we need an MDT approach to that. I often say, look, a lot of what I'm going to do is be resting you. Once I've rested you, we're going to try and go back in the opposite direction. And then I'm trying to keep you in this safe zone. So I want to stress you enough that you are not in pain, but making sure that they understand that a little bit of stress is absolutely needed. So complete rest is not an option, but too much is also not an option. So again, just using that language. We spoke earlier about if they've got a stress, which is no fracture, or they've got a fracture present. When they have an edema and just a little bit of stress, I normally say 6 to 8 weeks of rest, and normally in and around that stage 1 rehab in which I'll take you on to. And if it's a response, I normally say 12 to 14 weeks for a fracture. This gives it enough time to heal and create stability. And when I say rest, we're also going to be doing a lot of rehab stuff in that time period. Now, when someone's come to me with a confirmed stress injury, whether that would be a stress response, whether that be a partial fracture, a full fracture, or a fracture with a slip, my initial management is the same. I think, as Monty alluded to, was social media, sitting for long periods of time, exams, loads and loads of things. People are just not moving enough. So the first thing I'll look at is the fundamental of movement patterns. So I'll look at a hip hinge, a squat, an RDL, a single leg RDL, a horizontal row, a lunge, a press up, and a plank. These immediately give me, can this person move like an athlete? And did this injury happen because they can't move properly? That's the first thing I'll look at. The next thing I look at is lumbar spine and hip dissociation. Can they move their spine without moving their legs, and can they move their legs without moving their spine? It's just a concept of stability that I will ensure that I get people doing as soon as I see them. I look at deep core work, so pelvic tilting, and are they able to neutralize the spine? Another big thing is segmental mobility. So not only do I look at the lumbar spine, I'll also look at the thoracic spine, for example. Whereas, well, what I find is, especially 12 to around 17, lots of the kids are sitting in a flex position on their phones, exams, etc., etc. They have stiff thoracic spines, and when you are a bowler and you have a stiff thoracic spine, you overextend your lumbar spine, etc., etc., etc. Again, overloading your bowling. So again, massively to look at. I also look at hip mobility, hamstring length. When people are going through growth spurts, big things happen there. Ankle mobility and foot mechanics is something that I look at, but again, just an outside eye. Again, if it's not broken, I don't fix it. Workload and other sports is a big one that I look at. I always tell the kid, give me a diary of the last 4 weeks, and immediately they'll tell you if it's a workload related thing. Vitamin D and nutrition, I'll let Nick handle that. But yeah, again, something that I look at. Hypermobility is a big one. A lot of children that I see with hypermobility, they just move too much and lack stability. So then in my head, I'm going, right, this person will need more stability work rather than mobility work. Sports technique is a big one. You can look at all the body markers you want, but if the person during the bowling action is overside flexing and extending and their back foot's collapsing, they're going to overload one side of their back. So you have to look at that. It could be a throwing thing. It could be if they're a batter and they're cutting and pulling in the wrong way. Again, getting coaches involved, using the MDT is a huge thing. You get dad, get mum to show you videos of them doing their skill. A lot of people have that. I've got a video here on things that I look at. Let's just break it up a bit. It's not long, but it just shows some of the nice things that we've done in the past. So this is me looking at a child doing a hinge. Very simple, just use the stump. This is an overhead squat position. Just looking at their movement, single leg jump forward, seeing how they're moving. We'll again overhead from the side, looking at it at different angles. Are they overloading the spine here? This is just a press up to see if he's doing it right. Here, you can see he's massively overloading his lumbar spine. This is a young bowler, just taking him through some rear. So seeing how much his back foot was collapsing. This is the horizontal row I was talking about. This is another thing that I look at sometimes, which is a Copenhagen endurance to see whether they have weak adductors. This is me just looking at a guy in 4-point kneeling, just seeing whether he can move his arms and legs away while maintaining his lumbar spine. A lot of children with PAR injuries haven't the ability to do this. This is just me looking at thoracic range of him on the floor. Again, in the plank position, can he maintain a neutral lumbar spine? So yeah, just a nice little overview on some practical things that people can do. So the thing that what I was talking about with the phase 1 rehab, this is a phase where the MDT is quite important. So I'll be talking to consultants quite a bit. Do we need to re-image these patients? Do we not? But essentially, we need to allow the bone to heal in this phase, and that's immobilization if the consultant feels that's necessary. It's time off sport. It's in education of workloads to parents, to children, to teachers, to coaches. It's about nutrition advice. It's about how to structure a week properly. So the bottom line of this phase is why did this injury happen in the first place? So my assessment I spoke to you about will hopefully tell me why this injury happened. As it's so multifactorial, we have to put into some preventative measures, otherwise the same problem would happen again. What I like to do in this phase is allow them to cycle, I allow them to walk, I allow them to do some gentle jogs after about 4 weeks. But basically, I avoid rotation and impact, and all the exercises I do are in a straight line. So I do linear control work. So this is an example of something that I did the other week. I saw a patient and I created a problem list as such. And I said, look, he had poor vitamin D and poor eating habits. Go see Nick. I said, play 6 days in a row. I was like, right, only play in front of the most important eyes when you do get back. You can't just play in club and county and mess around with your friends, etc., etc., etc. So I spoke to him and dad about like using their timetable more efficiently. He had poor lumbar pelvic control. I gave him some exercises. He had poor fundamental movements. He could not hinge squat, horizontal or overhead squat. Again, I gave him the stick. I said, carry on. Um, he had a very poor bowling technique where he was falling over at the crease. I asked Dad to speak to coaches and said, when we do get him back, we need to rectify this. So let's start talking about that now. Poor hip mobility, I gave him some exercises, and he had weakness in his glutes, and I just gave him some banded control. This is just some examples of some exercises that I'll take you through. It's just just a couple of minutes. So this is something that I would do. So this is working on thoracic mobility, working on hamstring length here. So this is a 1990 hip opener. So just coming here, doing some banded lat stretches. This is some hip flexor work. This was just some extension work that we were doing. This was probably a bit later on. Hip openers. So this is the exercise we were saying. So just opening out. I wouldn't go into extension as much, but what I would do is more of the thoracic opening going up. This is just working into thoracic spine. So again, just some transverse abdominis work again. So just making sure they're able to neutralize the spine. Just some nerve gliders for hamstring work. Again, more controlled glute work. So this kid had a very stiff ankle, so we just gave him some ankle mobility drills. He's doing it poorly, but this was a rotational drill. This one, just a Bulgarian. We're doing some Copenhagen's with partners. Just looking at control and split squat. Yeah, and this is a single leg RDL. This kid was particularly bad at it, so just reinforcing those fundamental and movement patterns. So the exit criteria is quite important in this one. I would speak to the consultants quite a bit here and say, look, do we need to rescan this patient? Again, it's a conversation we have. If I feel as if they've rested enough, they're in no pain, they've had no symptoms, we don't really scan again. But some consultants very much love doing that, so happy with that also. I will always keep going back to my initial assessment. Have they reduced those fundamental risks? And if they haven't, we need to stay on phase one. I will never move somebody onto phase two if they've still got the same risk factors, because the same problem will keep happening again. Again, so just clearance of the subjective signs. Are you getting that morning pain? Tell me how it's been day to day. Does it hurt when you pick your school bag up, etc., etc.? Has parents noticed anything? Etc., etc. But now, hopefully, it's either 6 to 8 weeks or it's a 12 to 14 weeks based on the injury they had. So we go, right, more exciting. Let's move on to phase two. And in phase two, I've had a lot of success in trying to build capacity. So here I start introducing rotation and anti-rotational exercises. And what I do is I give them two plans. I'll give them a core related plan, and then I'll give them a strength related plan. So I start loading the fundamental of movement. So in phase one, they can now hinge, squat, RDL, horizontal row, plank, blah, 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 blah. I'll say now, right, let's start loading them. I normally keep the reps high and the weight low at this moment because it's all getting used to loading. Some kids would have never loaded before. I get asked a lot, is it too early to load? I don't think so. I think I've had people loading from 12 to 13, and if their movement patterns are good, I'm happy with it. Some of the examples I use here, I do GHR holds, I do some lower limb wipers, so the legs are going side to side, some Pallof walkouts, wood chops, side planks, Russian twists, and then the gym plan, goblet squats, RDL, single leg RDLs, exactly the same, just slightly loaded. Here, I'll also add a little bit of load, so I might do some more plyo-y work. So I might do some single double leg lands. I might do some assisted pogos, so they are getting that linear load through the spine. The things I look at here are a 2.5 minute plank, a minute and a half side plank, and then I get them to lie on the back, the side, the front, and on a GHR, or someone just holding the legs at the edge of the bed, and I try and get a minute and a half. But again, look, like I said, some people are way more athletic, some people are less. These are subject to change. They're not an absolute. Phase three is an important bit for me. I've got a video of 2 and 3 in which I'll share. But in phase three, I like to move on to now we've got capacity, let's build some stiffness, let's build some strength. So again, the plans are still split. The core plan, I'll focus on loading that patient. So a lot of the core exercises have now been weighted, rotational and linear and anti-rotational. So the GHR will have a weight on it. Wood chops will be a lot heavier, farmers carries, etc., etc. The second, the gym plan, I normally give a full body workout 2 to 3 times a week. I'll do very high weight, very low reps. We're not in that gray area of 8 reps. We're either doing 4 to 6 or 8 to 12. So I split it massively. How I love to do it is go hinge dominant day and a squat dominant day. So on a Tuesday I might give an RDL, and then that's the start of your workout. And then on the next it might be a squat dominant day. So they're not doing those two really important fundamental movements on the same day. Some examples here. I've spoken to you a few about them, but it's quite an important stage here where we're almost rebuilding the athlete to have a very good core and then be very, very strong as well through the gym, through the fundamental movement. Again, fundamental movement is the biggest thing. Can they move like an athlete? So this is a nice video. I'll try and rush through this one. But again, look, weighted squats. So this is the wipers. So again, so now we're getting some weight involved. This is the same guy using a bar. We're now doing a unilateral, kind of like a landmine rollout. So now we're starting to load the squat. Front squat's quite a good alternative if people are worried about doing back squats. You get a bit more core engagement. This is a very physio exercise, but just like an ISO hold at the front here. Quite a heavy band there. This is a great exercise. So this is an ISO walkout. This is a really nice exercise as well. So bowlers are in that overhead position. They're having to stabilize and walk forward, but you're maintaining a neutral lumbar spine. This is a nice one as well, just switching legs left to right, very bowling specific here, getting them at the crease, working on that back foot while their arm is up. This is some testing that we were doing just on some hamstring ISOs. But yeah, getting them loaded into a split position. Again, some more speed work here as well. Just introducing a bit of speed work. Again, I'll come on to this, but we're starting to do some work into more bowling work. So in stage three is where I normally introduce sport. Some people introduce it a little bit earlier. I say up to 50% to 75%, we go back to running. We'll introduce something called walk-through bowling. I get them to bat here. I sometimes get them to bat in phase two, and fielding and throwing can commence, focusing on accelerating, decelerating, and turning. And again, 50 to 75%. My main take-home message for everyone here is to go expose them in rehab first before the sport. So never allow anyone to get straight into the sport if you haven't exposed them in rehab first. This is an example, sorry, it's a bit blurry, but this is an example of a return to bowling plan. So this was one from 2024, but I got this patient to do a couple of 4 overs on the week one, then upped him to 6 overs and 4 overs, and just increased him to about 50%. Then I gave him 10 overs at 50% on that third week, and then he was up to 6 overs at 50 and 4 overs at 75. But I would urge everyone to do a controlled plan so they know exactly why they're doing and what they're doing. Again, I'm not going to go through this too much, but again, a couple of exits that I look at. Can they body weight one? Can they back squat 1 to 1.5 times the body weight, RDL 1.5 and above? I also look at the 3 reps, so preseason data, but I appreciate not everyone has that. 3 minute plank time, 2 minute, and the 2 minute side plank. I also look at any adverse effects from bowling, walkthroughs, and throwing. Phase four is the important one. It's the one where you actually put everything together and you work on power and storage loading. Can that person catch and then eccentrically hold and then redo that force essentially? So we're building lots of power, lots of explosiveness, lots and lots of throwing. A lot of children find this bit the most fun. Lots of uncontrolled diving, return to sport now. And we're now pushing from 75 to 100% and return back into play. So this is the last video. This is some of the level 3 and maybe some of the level 4 stuff. So we're ramping up the bowling now. We're getting them into more sport-specific positions. This is a really nice exercise where we're just really slamming heavy balls into the floor. We're now taking load and then re-going with the loads left to right. We're trying to move that weight quite quickly. But now we're taking force and bowling through. This is a really nice exercise for a quick snap for a cricketer. This is also a very nice one on the bottom of the step. So this is an RDL into a snap overhead, very cricket specific. This was a landmine in a more controlled one. This is one of the bowling coaches made this one up. This is a nice snap exercise. Again, very snappy movement. So now we're loading and we're using eccentric load on a leg press here. They're really pushing through that weight. Again, here as well, just trying to load, trying to get that power. This is a nice one. We're just flicking left to right on hamstring, so we're getting a little bit of speed work going as well. So this is a nice one as well. We're trying to develop him. This was Ethan trying to just get him to jump as high as he could. Under bands. This is a nice one, just trying to absorb some load. And then drop jump, we're trying, again, using his hip flexors a bit, but just trying to get him to jump as high as he can. This is some loaded pogos, trying to get his knees locked, trying to get some ankle stiffness here. This is a really lovely one for not only backs, but also shoulders, trying to get some thoracic extension and create some force. This is a nice one, some bowling with a med ball. You're trying to complete that action, just getting some really big side-to-side movements here. This is the really explosive wood chop. So yeah, just some nice examples there. But yeah, just my main thing is expose them in rehab before we go into sport. Always try and split your plans to left and right, and core, and then core as well as gym plans. But basically, my main take home is stage 1 is fix the problem. If this is so multifactorial, you have to figure out why they had it in the first place. And then do some linear work. Stage 2, once you've spoken to consultants, you can do some more rotational work and capacity. Stage 3 is develop some strength and some jumping. Stage 4, loss of power and showing off that big strength that you've made. And also some top tips, fix the issue, otherwise it will happen again. The amount of re-injuries that people get because you don't do the correct preventative rehab always reassess at each stage, expose them in training before the sport. MDT approach will always win, and respect the schedule of the school, the pressure that the child is going through. And a big one is when children play in ages that slightly higher. So if you've got a 12-year-old playing under 14s or men's cricket, their body sometimes doesn't handle the load of the sport going up. So again, something to look at. But yeah, that's my aim and address if anybody wants to ask me anything. But yeah, thank you so much.
Awesome. Thanks, Vish. There was just so much insight and so much complexity to that topic. So I think you broke it down really nicely and gave some really cool examples as well of some of the exercises that you're doing, especially towards baseball. So I appreciate that. All right, we're going to pass on to Nicola now, who's going to be talking about the really important role of nutrition and energy availability in bone stress injuries and the management of them. So all for you, Nicola.
Thank you very much, Sam, and thank you, Vish and Monty, for your presentations. Let me just pull up my slides. Can you see those slides? Yeah? Okay, let me just move something out of the way here. Okay. So yes, I'm Nicola. I'm a registered dietitian and sports nutritionist, and I have 15 years experience as a clinical dietitian, 10 years of which have been within the area of sports and exercise nutrition. And whilst I have experience across several different areas, my main speciality within sports is relative energy deficiency in sport and also those living with eating disorders or disordered eating. And so because of that, bone stress injuries often feature as part of the clinical picture, and it might be the catalyst for someone being referred for nutrition support. So I'm really happy to be here to talk about this topic with you all today. And it is quite a big topic. And I know I've only got sort of 15, 20 minutes, so I will do my best to squeeze it all in to give you a whistle-stop tour of the role of nutrition or fueling to support bone health for the prevention of REDS, a feature of which may be a bone stress injury. And I know that we've got a mix of clinicians and non-clinicians today, so what I'm going to attempt to do is to provide you with a general overview that's going to be useful for both. So we'll start by exploring some definitions specifically to do with the concept of energy availability. We'll then talk about the relationship between low energy availability and bone stress injuries in the young athlete. I will also share with you some common red flags to keep an eye out for in terms of low energy availability, some specific screening tools for the clinicians amongst us, and then we will talk about the key principles of fueling. If we've got time, I'll share a really quick case study with you because I'm eager to invite your thoughts on what might be going on in that case. And then we will have a bit of a summary and a panel discussion to follow. So first, let's take a moment to define what we mean by energy availability, as it is fundamental in preventing bone stress injuries and relative energy deficiency in sport. This is because if energy availability is inadequate, it can be the root cause or a major contributing factor in the development of bone stress injuries in young athletes. So the IOC, the International Olympic Committee, defines energy availability as the dietary energy that is left over and available for optimum function of body systems after accounting for the energy expended from exercise. So in simple terms, it's basically the number of calories that are left after exercise that's available to support normal physiology. And when we talk about normal physiology, we're talking about everything from digestion to temperature regulation to hormonal health, and of course, bone remodeling. Now, sometimes you see energy availability expressed as an equation, sort of mathematically, where exercise energy expenditure is deducted from energy intake and then divided by fat-free mass. But in the youth athlete, we don't actually have any universal accepted sort of energy availability cutoff. So instead, we're relying on clinical indicators, and we'll come on to talk about that in a moment in terms of growth, bone stress injuries, menstrual dysfunction, delayed puberty, that sort of thing. So what happens if there is insufficient energy left to support the body after exercise? That is what we call low energy availability. And essentially what happens is the body will down-regulate the supply of energy to processes that are not considered essential for immediate survival. One thing I want to sort of add is that low energy availability isn't necessarily always problematic. It's normal for some athletes to be exposed to periods of what we would say transient low energy availability, like if they've had a period of intensified training. But if the exposure to low energy availability persists, if it's prolonged or it goes on longer than the body can tolerate safely, that's when it can lead to harm. And so this is where relative energy deficiency in sport comes into the picture, or REDS or REDS, and that refers to a collection or a syndrome of impaired health and performance outcomes that arise due to exposure to problematic low energy availability. And a common feature of that is a bone stress injury. So this is where we start to see the relationship between low energy availability and bone stress injury emerge. So hopefully you're still with me, as I know that was quite a lot of definition to get. Relationship between low energy availability and bone stress injuries and how they arise in young athletes. Well, what we need to think about is some sort of unique characteristics of being a youth athlete that make the risk of low energy availability exposure much higher. The first being that energy needs for youth athletes are generally high, and they're often higher than in adults. And that is because of the energy demand associated with growth and development. So when we try to estimate what someone's total daily energy requirements might be, we need to add up a series of things. One of them is the basal metabolic rate. One is the energy cost of activity, so daily life, like going to school, hanging out with your friends, for example. But we also need to add in the energy cost of exercise, so training and competition, as well as the energy cost of digestion. And then in youth athletes, we have to throw in the energy cost of growth and development as well. And as a consequence, the energy demand for that young athlete is really high. And so there are some ballpark figures here on my screen. There is, of course, individual variability, but just to give you an idea, it's over 3,500 calories for males and over 3,000 calories for females. So another really important consideration is to do with the development of peak bone mass. It is generally achieved by about the age of 18, and it's a really important factor to reduce the risk of future fractures. Maintaining peak bone mass into adulthood is fundamental. So if peak bone mass is not achieved by that young age, we can't compensate for that later in life. And we know that genetics remain a really significant predictor of peak bone mass. But if that young person is exposed to low energy availability during that phase, then they might not reach that genetically determined peak bone mass. And that increases their risk of bone stress injuries at any stage of life. Now, we know that physical activity that involves high impact activity in teenagers and adolescents is really well recognized as having a positive effect on bone mineral density, but that is only true in the presence of energy balance. And that is why energy is the number one nutritional factor when thinking about supporting a youth athlete. And I also wanted to touch on another unique characteristic for young female athletes, and that's to do with the age of menarche, so the first period, because it can also be an indicator of bone stress injury risk. It's really hard for a lot of female athletes to achieve sufficient energy intake to establish and maintain a regular menstrual cycle when they're training at a really high load. And we often see this in delayed menarche. So the average age of menarche, that first period, is around 12 and a half years of age. But delayed menarche is actually common amongst adolescent athletes, so over the age of 15. particularly if they're participating in, let's say, a sport with an aesthetic focus or a weight class focus, something like gymnastics or cross country or rowing or dance. And so menarche that takes place over the age of 15 is associated with a higher rate of bone stress injury. So you can start to see how there are lots of unique characteristics of being a youth athlete that put them in a position of being exposed to low energy availability and a higher risk of bone stress injuries. And so what you can see in red is this sort of cascade. If there is insufficient energy in the system, the brain will detect it, and a hormonal chain reaction is set off where essentially hormones for bone growth decrease, bone remodeling slows, bone stress injury risk increases. So how might we keep an eye out for low energy availability? And Vish and Monty have already alluded to a number of red flags that they notice within their clinical practice. These are some red flags that I consider to be the signs and symptoms an athlete may present with that could point you to a suspicion of low energy availability. And it's really important to be alert to these because they can help us to identify low energy availability early and intervene before the bone is actually compromised. Practice is that many of these red flags, they might be overlooked by the athlete, or the systems within which the athlete is operating or living, they may lack the knowledge or awareness, or some of these things might even be considered normal or acceptable within some sporting cultures. So it's really important that any clinician here or any non-clinician here starts to keep an eye out or have an awareness for some of these red flags. So this might be, for example, a performance plateau. Are you noticing a mismatch between the level of training and the performance? This might present as a feeling of underperformance despite someone putting in a lot of hard work. Maybe there is poor recovery, so muscular soreness, fatigue, a lack of readiness for the next session is often something we see. Maybe there are reoccurring soft tissue injuries as well, things like tendinopathies. A really common one is reoccurring illness. So low energy availability can compromise the immune system. Maybe the young athlete is presenting with frequent upper respiratory tract infections. Maybe they're missing school a lot, so frequent days off school. Maybe they're missing training a lot. That would be a red flag or a warning sign. Then there are some other more well-known ones: bone pain, shin pain, maybe slowed growth. If they're having their growth monitored on a growth chart, are they slipping off the trajectory that they're expected to be on? Is there delayed puberty or delayed menarche or absent or irregular periods? So we've got some more clinical factors here. But there's also some other nutritional red flags. If someone's total food consumption is below where it needs to be, it might mean that other nutrients are compromised too. So maybe there's an iron deficiency, for example, or something else. And maybe there are some red flags in terms of behavioral elements. Is this young person skipping meals? Are they not around to have breakfast? Are they training rather than having breakfast? Are you noticing differences in how they interact with food? Maybe they've decided to start a new diet, something they've seen on social media, for example. So all of these things are early warning signs for low energy availability. So for the clinicians amongst us, if you notice these red flags, there are a number of screening tools that are available. Unfortunately, for the youth athlete, there is no widely accepted, fully validated screening tool for low energy availability or REDS, but I wanted to include a list of the ones that do exist for older adolescents, so those over the age of 16, and also for adults, because actually the questions within them are still relevant, they're still pertinent. But what you can see highlighted in purple is something called the RED-S CAT2, which is probably the most useful assessment framework for youth athletes, as it includes youth-specific markers like growth, delayed menarche, for example. So that is something I'd encourage you to have a look at. So over the next 2 slides, I wanted to share some key nutrition principles with you to help a youth athlete fuel well and to prevent bone stress injuries or REDS. And the first principle is energy, arguably the number one priority. And to get this right, we typically split up fueling into two categories. We have daily nutrition and acute fueling strategies. So the day-to-day principles are all about eating regularly. And that might sound very simple, but it can actually be very difficult for a youth athlete to achieve that when they have such a congested timetable and so many demands on their time. But 3 meals and 2 to 3 snacks per day at a minimum. We also talk about adequacy, so eating all food groups. That means each meal ideally needs to be balanced, or at least all food groups to feature across the day in terms of carbohydrate, protein, fat, and fiber, and an even distribution of carbohydrate and protein spread out across the day. This might mean having to top up what is provided by school or what they're already taking into school. And then we have acute fueling strategies, and that is specifically around training and competition. So we're thinking about carbohydrate before, carbohydrate during, and we're thinking about carbohydrate and protein to refuel and repair afterwards. And so acute fueling strategies are like separate from day-to-day nutrition. We need to make sure that training session is packaged up with fuel before, during, and after. And then the next principle is to do with protein consumption, which is so important for musculoskeletal development generally. Sufficient protein is key to support a youth athlete to adapt from their training, to recover from their training. And if they're injured and they have a bone stress injury, then actually protein needs are going to increase to counter muscle loss, especially if there is an immobilized limb. And the final principle is to do with vitamin D and calcium. They go hand in hand. So in order for the body to sufficiently absorb calcium, we need adequate vitamin D. And the calcium requirements of a young person are higher than an adult. Adults are around 700 milligrams a day. For a youth athlete or a young person, it's around 1,300 milligrams a day. Practically, that translates into at least 3 servings of dairy or fortified dairy alternative every day. And usually vitamin D supplementation is required as well. So Sam, hopefully I've got time just for a really quick case study. Would that be okay? Thank you. So I wanted to invite you to use the Q&A box just to share your thoughts on this case study. So I wanted to let you know about a 15-year-old female who's a middle distance runner. She goes to school Monday to Friday, 8 a.m. to 4 p.m., and she competes on the weekends. She trains before and after school at least 4 or 5 days of the week. She tends to skip lunch. She's recently gone vegan, and she presents to clinic with a lumbar bone stress injury. And I wondered what your thoughts on that were and what questions or what information you might like to find out about her. So if you're comfortable to, please use the Q&A box to pop your thoughts in there. Yeah, great question from Claire. Is she still having regular periods? The answer to that is no, she actually hasn't started yet. Her menarche is delayed. Is she, what's the reason she's skipping lunch? Yeah, so she wanted to hang out with her friends at lunch, and apparently lunch isn't a thing amongst her social circle. What does a typical day of eating look like? Yeah, so there were really long gaps between her meals, exactly. Energy levels and performance. Yeah, so her energy levels and performance were falling off a cliff, unfortunately. Yeah. So these are all really good questions, and they give us a lot more insight into what might be going on for this individual. She was absolutely in a state of low energy availability and relative energy deficiency in sport. I'm just going to open that one more time and see if there were any other. Does she feel before or after training? No, she was training fasted in the morning. Yeah. Yeah, so lots of really great questions. Thank you for sharing those. Okay. So my key takeaway from this is that energy availability is arguably the most important consideration for both the prevention and management. You've seen from today's session is that often underfueling is the problem, not just an overuse problem. So it can be the two combined. That youth athletes are particularly vulnerable to bone stress injuries and low energy availability, and that's multifactorial. But all of us, whether we're clinicians, non-clinicians, can be proactive to spot the signs of underfueling early so that we can prevent injury. So thank you for listening to me, and apologies for the sort of rattling through the last bit of the case study, but it was great to see your questions all really relevant and important to ask. So thank you, Sam. Back over to you.
Thank you so much, Nicola. I feel like that case study is definitely something you would see a lot of, and even I think us as physios, we see a lot of. And I love that little comment. It's not a thing in a friendship group. Yeah, sounds like my sister when she was 15. We're going to run through some of your questions now. So I'm going to try and consolidate a few that overlap that we've got here. So the first I'm going to ask is to Monty. There's been a few questions sort of speaking about in the NHS, just the availability of scans. So one of the people said that she's a private clinician. She works with young athletes and she has issues with getting kids into NHS pathways. They'll often get sent to a GP, might get prescribed pain relief and then get lost to the system. Do you have any advice for clinicians or parents in helping to get kids into NHS pathways where they can be appropriately managed?
Wow, that's a long there's a long answer to that. I guess first of all you need to decide if it's acute or an elective thing. So you trying to get it into an outpatient or is there an acute issue of pain from a sport event? So I'm going to obviously the former, if it's acute event, then you're going to A&E. So that's actually, to be honest, one way of getting in the pathway. The other is it really depends on your location. Unfortunately, everywhere has different pathways into how you get into it. So normally the pathway would be GP to pediatric orthopedic specialist. That's what I normally advise people to do. And again, waiting times can vary per region or location, even within London. Access to scans again is variable. So I know in spine care for adults, for instance, in Northeast London, Essex, GPs are now no longer allowed to request scans, MRI scans. It has to go through a certain pathway where it goes to ESP, like a senior physio, advanced health practitioner type person. It's triaged, and some of it might bounce back, some of it might go to the urgent or normal pathway. There is normally in most regions now a triage type pathway for kids as well. Unfortunately, that's the situation. There isn't the whole philosophy of the NHS now is to stop people scanning people all the time. So it's quite difficult. It's getting harder and harder in the NHS to get a community MRI scanner. A community MRI scan for someone. It's difficult because unfortunately it varies per region.
It's really tricky. Obviously, as someone who has not grown up in the NHS system, I know the complexities around it. So thank you for that. I appreciate the insight there, Monty.
It's very difficult. Very difficult to, it's either A&E or you wait, 4 months or whatever. If you've got a fracture, it's simple. You go through a fracture pathway. That's, a wrist, elbow, whatever. And sometimes the easiest way is just go to A&E, which is unfortunate. That's why people queue up in A&E.
Yeah, that's a tough one. Doesn't seem like there's much of an answer in the long term, but definitely some things that people can access. So thank you. There's another one, I guess, sort of trying to consolidate a few questions here. Broadly looking at devices, you mentioned osteospine, Monty, but for vision, Monty, we've got some people asking about Exogen, looking at also PEMP, so pulse electromagnetic field NV ultrasounds, also looking at a multifidus stimulator. I think that's a device where you would then put probes into the multifidus trying to stimulate that muscle. What are both of your insights in terms of looking at devices to help assist and be adjuncts for treatment?
Yeah, I can answer that first. So I'd say two things. You need someone who's specialized from a rheumatological sports medicine point of view. That's why I use John Hatton, because there's very few people around who are dual trained in rheumatology and sports. And so the past stress injury stuff fits nicely into that. So that with regards to the stimulator, the osteospine, and with regards to potential for medication. And the second thing is a physio like Vishal, who's specialized in this as well. I think PARS does. I mean, obviously, not everyone can see a physio who specializes in PARS injuries, but the more sport you do and the higher level it is, I think the more importance there is attached to that. And then they can use their experience to decide whether you need a multiple stimulator or whether you might need to be referred for this osteospine or whatever. That's the only kind of bit of advice I'd give.
To be honest, I don't tend to use them at all. Yeah, I've seen it and I've spoken to John about it. I've even spoken to Monty about it. But I feel as if if you get your stages right and you allow that person to heal, and don't rush them, yeah, I don't think that I personally I wouldn't recommend. But if you've got somebody who's got a massive timeline and you've got a World Cup final in 3 weeks, then it's worth throwing it. Yeah, exactly. So it's worth throwing maybe as much as you can at it. But yeah, I'm not a, yeah, I'm not, I really believe in getting the healing times right, respecting the body and respecting healing time.
Think what has been a really nice constant across all the three different speakers tonight is just the importance of taking a really thorough subjective, going through the different phases and not rushing things and addressing problems before they arise and ensuring that you're assessing why this has happened, not just how do we treat it or how do we fix the problem. Um, I think we've got time for one more question. We also have been answering a few of the questions online. Hopefully, you can see some of the answered responses. To those that we haven't got a chance to get to tonight, we will be answering these, so they'll come through later as well, and you'll be getting access to this recording too. Um, this one is for Nicola. In terms of looking at Red S and disordered eating, there was a good question about whether this is something that occurs in isolation or if they're always linked together. What would be the relationship between Red S and disordered eating?
Yeah, it's a really good question. And RED-S can, well, disordered eating or eating disorder puts an individual at greater risk of the development of RED-S. But RED-S can exist with or without disordered eating or eating disorders. So they can coexist, and they also don't necessarily. So there are some really useful eating disorder screening tools that would be specific to eating disorder or disordered eating to help reveal if that's the case. But any really good clinical interview, any really thorough assessment will help to reveal whether the root cause of that low energy availability is unintentional, purely as a consequence of a lack of knowledge, the practical challenges that they're, facing, or whether actually there is disordered eating or an eating disorder at play.
Thank you so much. I think that is all we've got time for, everyone. Thank you so much for attending. We really appreciate you taking the time on a Thursday evening to come and join us in our webinar. And we hope that you've learned a little bit and had some either myths busted or some insight into the complexity, but also the understanding of this topic. So thank you, everyone. We will make this recording available and will be sent out to you on email, and we will try and answer all those questions as well to the ones we haven't gotten to in our panel or answered on the Q&A. Have a good night, everyone, and thank you so much to Vish, to Monty, and to Nicola for speaking. We really appreciate your time, guys.
Thank you, everyone.
Thank you.
Bye, everyone.